The final speaker in our session this afternoon is Hilary Pinnock, who is a Professor of Primary Respiratory Care Medicine at the University of Edinburgh. So she leads programs of work at the Asthma UK Centre for Applied Research and the Respire Global Healthcare Unit, funded by the National Institute of Health. She's a chair of the Education Council of ERS and been actively involved with the International Primary Care Respiratory Group. So it'll be really interesting to hear Hilary's take this afternoon on where we are with connected digital respiratory care. Thank you.
Thank you very much, and thank you to the organisers of this meeting for inviting me. It's been a really interesting afternoon. What a spectrum of talks that we've had. I think some of the things I'm going to say are going to pick up on quite a lot of those. A declaration of interest. I'm not going to make any money out of today, but my declaration is there for you. So what I want to cover, I was asked to talk about an initiative that I'm leading with Job van Boven from the Netherlands, the Connect clinical research collaboration that's supported by the European Respiratory Society. And I was asked to talk about why we thought this was an important initiative, and then just a little bit about our vision, our aims, and what we're planning to do. So why Connect? And I think if I was restricted to one slide, I'd probably put this one up. And it's two words, really. It's digital transformation. And if you just read that statement there, currently undergoing a thorough digital transformation that stands to change the historic, just listen to this, the historical dynamic between healthcare professionals, patients, the private and public sectors, and the health ecosystem overall. Are you kind of stunned into a sense of what's happening? So I think that is really where we were coming from when we started to talk about this, because actually it's not a question of if it's going to happen. It's a question of when and how. And indeed, we've already heard many examples to suggest it is already happening, but it's a question of how we can make that happen, given the change to the historical dynamics, which to people of my years anyway, certainly sounds rather scary. So that's perhaps the overarching thought. Now, the World Health Organization have something to say about this. From their point of view, digital transformation, they agree, disruptive. You don't need to read all of that slide. There are a lot of examples on there. The point, though, is that technologies have, from their perspective, proven potential to enhance health outcomes. So they're seeing it as something positive, but disruptive. And from their point of view, one of the key advantages is the idea of enabling universal health coverage, which could not be achieved without e-health. Obviously, this is in order to overcome distance and where services are distributed widely. So, and I think this is interesting, given the talk about digital inequities. They see it as a way of improving equity in access to health coverage. And these are some pictures from their reports, different ages. What interested me, though, is how many of them are young people. Just look at that girl over there. She reminds me of my granddaughter, who at the age of about 3 picked up a piece of Lego, those of you who know Lego, the flat bits, held it to her ear for a mobile phone. And that was with parents who were really paranoid about not using their mobile phone in front of their daughter. So maybe it's a problem for me, but when this little girl grows up, maybe it won't be such a problem as I see it as. But access is complex. And this is a schema that's been produced. It's around access. You've got to have access to the various providers, whether that's organizations, systems, or individuals, but you also need to be able to access. So whether it's a population that has the connectivity to be able to access, or individuals who are able to have the health literacy to access the healthcare. So it's not a simple question of, well, here's a phone, here's a digital connection, you've got access. And we realized that, didn't we, when we did go digital by default. digital by default always reduces the accessibility for the deprived populations who, and I like this term, whose use of technology is of necessity frugal. We realised this in the context of the pandemic when all my consultations looked like this. And we realised that the people who were struggling most were the people who were in deprived or who most needed the care. So why did we want to talk about Connect? We wanted to think about avoiding digital inequities. We were aware that studies are mostly conducted in high-income countries, and that may not be transferable. We know that there are gender issues where very often in many countries there is a mobile phone, a smartphone in a family, but it's the young male that's got it, not the person in the family who perhaps most needs it. We do know that we can overcome many of these problems. This clunky piece of kit at the bottom here doesn't look like state-of-the-art, but it did mean that our elderly COPD patients were able to use it. They did put a tea towel over the webcam, though, because they were scared it was going to watch them. The dynamics of remote care are really interesting. These are typical pictures of consultations. This is how you imagine a consultation. What's the common theme here? It's the laying on of hands. Well, you can't do that digitally. So we've lost something about that traditional dynamic. As one GP said, interviewed about digital healthcare, you can't offer a tissue in a remote consultation. And there's a lot of concern about the loss of humanness. That picture at the top there wouldn't look quite so connected and human if those two figures weren't leaning out of their screens. And then from the individual's point of view, I'm sorry I haven't got your app on here, Rob, nor the other 250 that are coming up every day. But from the patient's point of view, they've got all these apps, but they don't connect. So if they want an inhaler, want something that's monitoring their inhaler, want to deal with their mood, want to think about the environment, they need a different app for anything. It's anything but connected. And of course, it doesn't often connect with the clinical systems either. The patient needs to be able to choose, and they need to be connected together in some way, and seamlessly, and connecting with us as clinicians. I'm not even going to go there with artificial intelligence and the lack of trust that is currently there amongst many patients and many clinicians, despite the fact that, as we've been told, it's already happening. So within this context, the ERS was interested in how we implemented connected care, and they've supported a number of initiatives which have finally resulted in the Connect clinical research collaboration. These collaborations, CRCs, are designed to get a network together to think about what could be done to advance research in a given area. They're almost all disease specific. Connect is very different because we connect all these CRCs and all the assemblies within the ERS. And we've got 5 overarching aims. First of all, we want to deliver a network, and we are already doing this. We actually have just over 900 members from 80 countries around the world who've signed up to be part of this network. We want to create a repository of respiratory healthcare technologies, and we are talking with an EU initiative that's already doing this in other disease areas, and we're looking at whether we can add respiratory technologies to that. We are already starting to undertake a systematic scoping review about implementation research. What has been done to implement in routine practice, not pilot studies, not testing whether something works, but actually implementing it in routine care. And we're looking at a scoping review on that at the moment. Ultimately, we want to develop some position papers about what policy can do, what patient barriers there are, about the professional barriers, the organizational barriers, and some of the regulations for secondary use. We want to develop some position papers, and particularly thinking, of course, about children and the particular implications for them. We're interested in working with the outcome measures. You know, when can we use digital outcomes for regulatory approvals? And this is something which has been done in the States with the FDA, but we need to perhaps think about something in Europe. And finally, we want to develop some research applications, probably along with other colleagues. Some of them will be exploring those overarching themes. Some will be supporting work packages in disease-specific applications. And we've got one that we're already starting with Dragon, which is an IHI grant, where we're going to be looking at the impact, or trying to understand this impact of digital healthcare on the clinician-professional relationship. And we have a piece of work just starting now, looking at a systematic review and getting stakeholder discussions around that. And finally, of course, we're publishing. If you want to know more, we have an editorial in the ERJ that came out very recently, and an ERS monograph that was published only a couple of days ago. So it's not if, but it's how. And these are our overarching aims. I'm sure they will evolve over the 3 years of this CRC, but the ultimate aim is to promote and support implementation research into digital respiratory health that is sustainable, equitable, and appropriately connected. So thank you for listening, and I hope you enjoy Edinburgh despite the cold weather and your conference. Thank you.